3-year-old Umar Modu was discharged as cured of severe acute malnutrition 6 months ago, but he relapsed and is back at the Shuari Outpatient Therapeutic Program (OTP) in Jere in Nigeria's northeastern state of Borno, where he was earlier treated. The facility is run by the International Medical Corps Nigeria, a USAID-funded program.
Tada Umar Sunzo, Bande Modu Sunzo. Tada Koswata Mai Suta, Shuari Bonge Iskana, Sanga Wedin. Shuari Bonge Iskana, Galozo and just Salamana, Kurwalti Chins, Kutro Walzu, Yertaisha Suta Bonye, Kurshuari Kai.
Falmata said there was no disease outbreak in her neighborhood during the time her child relapsed, and he had so far not been diagnosed with any other disease aside severe acute malnutrition. She has been living at the Shuari police station internally displaced persons camp since insurgents attacked her community 6 years ago. Both Falmata and her husband were smallholder farmers in Dala before they were uprooted from their home by the violence. They have not been earning income since then and depend on food occasionally distributed by Save the Children International at her camp. But such a handout barely meets the nutritional upkeep of her family. She just cooks whatever food she gets and everyone in the household eats. Her household diet remained the same, in addition to poor water and sanitation facilities in the camp. A few months after Umar's treatment, he relapsed. Severe acute malnutrition has continued to ravage children in conflict settings such as Borno State in northeast Nigeria. In some cases, children under 5 who were treated and discharged from outpatient and inpatient outlets relapsed and returned for the same treatment. About 2.5 million children below 5 years have severe acute malnutrition, according to the United Nations Children's Fund, UNICEF, with about 420,000 deaths recorded. A December 2020 UNICEF report predicted a surge in cases in northeast Nigeria. Also, last December, Doctors Without Borders, also known as Médecins Sans Frontières, MSF Belgium, had treated exceptionally high number of children with severe acute malnutrition in Borno than the previous year. United Nations agencies estimate that about 3.2 million children will face malnutrition in northeast Nigeria this year. Experts say the malnutrition rate for Borno State alone is above 20%, and this is considered an emergency. In recent years, programs have been put in place to treat severe acute malnutrition. Children with the condition in Nigeria are usually treated through an outpatient therapeutic program of the community-based management of acute malnutrition. But some of the children who have been treated still face the risks of relapse. Relapse means to fall back into illness after a period of improvement or recovery. Someone is said to be experiencing severe acute malnutrition relapse if the disease returns or the person suffers an onset of symptoms again after improvement. Many children who have been cured of severe acute malnutrition in Nigeria have been in the circle of returning to the same treatment all over again, as the conditions that caused the illness never change. This predisposes the children to death. Those that survive face lifelong disabilities as they may never realize their full potential. The right thing to do is to never let the children be malnourished, according to early childhood development experts. And if they are ever acutely malnourished, they should be treated and prevented from relapsing. But their conditions in northeastern Nigeria is dire due to protracted violence that has killed thousands of people and displaced millions. In Nigeria's northeast, where Islamic militants have waged a war against government forces since 2009, there is no comprehensive data on severe acute malnutrition relapse. A 2020 study on the incidence of severe acute malnutrition relapse in Nigeria's northwestern state of Sokoto shows that about 24% of children cured of severe acute malnutrition in health facilities relapse within 6 months. The study was led by researchers at Oxford Policy Management and Valid International in collaboration with UNICEF Nigeria. So far, no survey has been conducted on cases of severe acute malnutrition relapse in Borno State, the epicenter of the insurgency, according to multiple health workers in the state who were interviewed.
Prevalence in Borno State has not been documented. There have not been, a survey done so far to actually, isolate or probably identify the rate of relapse. But in our program, in about 100 children that we successfully cure, about 2 usually come down with relapse. And the reason why these happen is not far-fetched. There are a lot of causes of relapse, that we noticed in our program so far.
4-year-old Fatima Harun was treated for severe acute malnutrition and discharged 4 months ago at the Jabamari OTP camp in Borno's capital, Maiduguri, also run by the International Medical Corps. She suffered a relapse and is now on another treatment at the facility.
Da fari ni ina cleaning a private school a nan anguwa. Tukuna baban kuma hard worker. Shine abincin kuma yanayin samun ba zai ishe mu yi abin da na gidanmu ba. In an ba mu tallafi ko abin ci dai haka ko jari haka shine zai ka, amma yanzu gaskiya ba mu da enough abin da zai kori wannan ciwo.
At the home of Hawa Mohammed, a widowed mother of 17-month-old Fatima Ali in the Gomari area of Maiduguri, a case of severe acute malnutrition relapse has been daunting. Mohammed said her daughter had faced a 9-month ordeal battling severe acute malnutrition and tuberculosis.
Farko ta fara rashin lafiya ba a ɗakin tamuwa ba. Ta fara zazzaɓi, hakan nan tana raguwa. Muna ta zuwa ana riƙe mu, an riƙe mu sau 2 a gefen ba 'yan tamuwa ba. Kullum kuma tana cikin ramewa, jikin yana ɗaukan zafi, ba irin alluran da ba a mana ba, an rasa gane zafin jikin nan ne. Wani lokaci na koma riƙe mu na 3 sai aka ce ta shiga tamuwa a Umar Shehu. Sai aka ce ta shiga tamuwa za a tura ni wajen rescue. Da aka tura ni sai aka riƙe mu a wajensu. Sai suka ce ba gado, suka kai ni mashamari muka zauna. Bayan mun dawo har yanzu jikin zafi baya sauka. Sai aka ƙara riƙe mu a Umar Shehu. To sai in ji daktan ta ce wannan zafin jikin da pneumonia ne, duk alluran da ya kamata a mana an mana. Tana ga tarin cibi ne, bari a je a yi hoton kirji a kwastin. Mun je sun biya an mana, an gama mana komai. Sai ta ɗaura mu akan maganin bari mu sha, ko da na sati ne a ga zafin jikin zai sauka ko ba zai sauka ba. In ya sauka shi ne. Ta yi gwaje-gwaje kuma aka ɗaura mu a magani, sai muka ga ta fara ƙiba, raman ya tafi kuma zafin jiki ya tafi. Sai ta ce to shi ne sai in je ne mu kula sosai, a riƙe mu so 6. Sai suka ba mu rufada da aka sallame mu, suka ce a ina za ki karɓa, na ce zan karɓa a Gomari. Sai na je ne na kai rufadan Gomari, sai aka ba mu a Gomari. Muna karɓa muna cikin karɓan aka ƙara riƙe mu ma. Da aka riƙe mu sai na ƙara dawowa wajen su. Me yasa ba kiya zuwa, na ce an riƙe mu ne gashi abin da yake damun yarinyar. Sai suka ci gaba da bamu. Da suka ci gaba da bamu, yanzu kan yarinyar ki tana ƙaruwa. Da kan muna bayarwa mun rasa me yake damunta. Sai na ce musu tari ne. Shikenan suka ci gaba da bamu, da katin ya cika ta warke sai aka sallame mu. Gaskiya da muka fara amfani da shi na ji daɗi, don jikinta ya dawo, ta lalace sosai, ko zama ba ta iya, da tana tsayuwa jinyan ya same ta, ya zama na babu zama babu rarrafe ga yunwa, duk ta lalace. Gaskiya tun da mai gidana ya rasu, kafin ya rasu ma damun ba shi da shi wahala muke sha, kuma ya zo ya rasu na shiga cikin wani hali. Wani sa'in na samu mun ci da yaran, wani sa'in gaskiya ba na samu.
Other areas across the state are also recording a high rate of severe acute malnutrition relapse for those in camps.
Akwai rahoto. Wani yana ɗaukar dogon lokaci, wani ko ba da ka san abin jiki ne. Kowa da yanda Allah ya dora mai nauyin jinya. Ko ba hanya ba. Na wani ya daɗe, na wani ba zai daɗe ba. Amma duk inda aka samu kamar wannan dole ne a samu wasu masu tamuwa. Yanayin yanzu da yake an hana ba da abincin nan.
Experts say there are reasons children under 5 relapse after treatment. Sefia Yunus, a nutrition officer at the Shuari OTP site treating Umar Modu, said about 2 relapse cases were recorded in 6 months in the facility.
We have poverty. If you can look at the situation, the inflation of the country, if a woman has no money, she won't have enough good food diet to have it at her home. Another one is food insecurity. As most of them are displaced, most of them are IDP camps, they have no access to a feasible and sustainable food within their catchment area. Also, if we look at the household level, maybe poor hygiene practice at their own side also can contribute to such. Because if you are not practicing good hygiene, a child may be contaminated with some microbes or germs, of which it will lead to diarrhea. As such, the child will be wasting and he will be losing weight. So he will be admitted as a SAM. Later also he will become relapse in the future. So also we have medical complications like poor immunization. If that child is not being immunized fully, the immunity of the child will be less. So he will be susceptible to so many diseases within. If there is any outbreak within the area he's living, so he can easily catch up with that disease that will retardate him to birth.
Ifeanyi Ojiaku, a nutrition assistant and team lead Jabamari OTP, where Fatima Harun is being treated, said the prevalence of relapse in the facility is between 2 to 3 cases in 6 months.
Actually, there are factors that lead to relapse of the beneficiary. One is poor immunization. If the child doesn't get the right vaccination as at when due, the child is most likely to get ill, and which will contribute to the child falling back to SAM. Is also a factor in relapse. Another factor that is responsible for a child going back to relapse is poor hygiene, poor personal hygiene being practiced in the family. So if there are poor hygiene practices in the family, the child is most likely to get infected from some ailments such as diarrhea, which could contribute to the child falling back to SAM. Another factor responsible for relapse is food insecurity. When there is no food in the house, when there is nothing to feed the child is most likely to fall into SAM. So after discharge, if there are no food items in the house to feed the child and to make sure that the child is healthy, is most likely that that child will fall back into SAM.
Olive Mutamia, humanitarian nutrition advisor, Save the Children International Maiduguri, says about 1% of beneficiaries come back with relapse after severe acute malnutrition treatment in the organization's treatment sites.
The relapse cases are about 1%. I can talk about 1% of relapses, like on a monthly basis, and that's across all the sites. But we find that some sites have more, others have less. But in a summary, we can see that about 1% of all our beneficiaries who understand from the program come back as relapses.
She said another contributory factor to relapse is caregivers taking their children to traditional medicine practitioners for treatment. Some
children will come even like every other time you discharge them, they are coming back. There are some children who will be coming back after every 2 months, they are back to the program. After 2 months, they are back to the program. At that point now, we have to refer them to the stabilization center, which is the inpatient, for further investigation to establish, is it just food or there is another underlying medical condition that is making them to be back every other time.
Mutamia said they've seen comorbidities in some of the affected children. Added that sometimes during the rainy season, diarrhea, malaria, and pneumonia are comorbidities they witness. Musa Tanko, data Analyst Activity Manager at the Médecins Sans Frontières MSF Belgium Therapeutic Feeding Center for malnourished children in Maiduguri, said in 2021 the facility recorded less than 1% relapse rate in the inpatient therapeutic feeding center.
Issue of relapse rate in facility, it's not too significant because we have a little percentage from our previous historical data. In 2021, we only have less than 1%, of which it's 0.5% in ITFC, while in ATFC we have 0.3% of relapse rate. And comparing to the previous historical data, I think in 2018 we had a high number of relapse, of which it's 1.4%, but there are some mitigations that were put in place in the project that really mitigates the relapse rate.
MSF has been present and responding to malnutrition in Maiduguri since 2016, and over the years we've seen the trend evolving. And while we would hope for the situation to improve, what we witnessed last year in 2021 was a dramatic increase of the cases we treated here in the hospital. So between 2020 and 2021, there was an increase of 31% of the patients we admitted here in the stabilization center.
Sangita Jacob Dugal, Nutrition Manager, UNICEF Nigeria Maiduguri Field Office, said the rate of relapse is small and below 1%.
The rate is very small rate. I can say below 1%, right? But the issue is much bigger. The issue is that when we are treating the children, we are treating only for SAM, because that is the mandate of UNICEF. But once they are treated, they are cured, they goes into a next phase, which is the moderate acute malnutrition, and then from there they move to the general malnutrition, and then finally they become cured. Completely cured means the normal child, right? So relapse happens in two conditions. One, when the child is discharged normally, cured from the SAM treatment, after going back, there is no treatment at home.
Dugal explained that if the child doesn't go through that process and has an episode of diarrhea or any sickness, and the mother is not able to feed the child properly, the child comes back to the severe acute malnutrition category, and that is where the challenge is. She said families must understand that after discharge, the children require support like more feeding, active care for the baby, including drinking water and hand washing, among others. On prevention of relapse after severe acute malnutrition treatment in children under 5, Sangita said one very important way is empowering families of children who are admitted to stabilization centers. She said it is also important for health workers to keep track of discharged children so that they do not fall back into the severe acute malnutrition category again.
UNICEF is working towards all these things. And most importantly, it is the empowering of families. Secondly, also for the health facility workers to keep a track of those children who are discharged so that they don't fall back into the SAM category again.
On the alleged diversion of ready-to-use therapeutic food meant for children, she said across the world, wherever there is food insecurity, misuse and intra-family distribution of the therapeutic food is rampant.
People generally, especially in Africa, RUTF, because it is made of peanut butter, they consider it as a food item. They never consider it a medical nutrition therapy.
Ifeanyi Ojiaku, the nutrition assistant and team lead, Jabamari OTP, said sensitization on personal hygiene, food security, and proper immunization would help to prevent relapse after severe acute malnutrition treatment.
After discharge, linking the beneficiary to the appropriate humanitarian partner that implements, that tackles food insecurity, that implements FSL, Food and Security Livelihood, so that after discharge, if that beneficiary can also have access to food if it's not available in the house. And then lastly is linkage to other humanitarian actors that implement livelihood. So we link them to, if they don't have any work they are doing, would link them up with other humanitarian partners that provide source of livelihood. That way they'll be able to sustain their family.
Dr. Jetola, the IMC Nutrition Coordinator, called on governments to ensure integration of food security and livelihood programs and WASH programs into the existing health structure.
In our program, we designed the program in a way to actually ensure the prevention of malnutrition and treatment of relapse. There is the SBCC part, the social behavioral change communication part of the program, which addresses, the use of complementary feeding, where we teach the mothers on how to cook nutritious meal like Tom Brown, like some nutritious locally sourced ingredients, and also where we offer them nutritional counseling on maternal, infant, and young child feeding. In this program, we believe that the first 1,000 days of life is very important to a child's growth. So we usually offer counseling to pregnant and lactating women who have children inside of them, to actually know what to do in terms of nutritious meal, because the meal the mother takes also helps the child. Also in the program, we offer one-on-one IOSF counseling, infant and young child children counseling, which is the form of preventive measure to ensure that children don't come down with severe malnutrition. There we teach caregivers on how to combine different food classes to ensure their children that after being discharged have access to nutritious meal. I think that's the role the nutrition access to food security actually played in the program so far. A lot of efforts actually have to be made to prevent relapse. As we noticed in our program, we noticed that the insurgency itself had actually contributed to food insecurity, which had further given rise to acute malnutrition and relapse. We need to actually strengthen food security mechanism to ensure every household have access to nutritious meal to prevent children from coming down with acute malnutrition. Also, poor uptake of health services is a sociocultural thing that is common in every part of Africa. People prefer the local herbalist than the orthodox medicine. So here we have people. We notice in our program that some children don't have adequate access to routine immunization, and these immunizations are supposed to prevent children from coming down with diseases like measles, like yellow fever. So all those are actually contributed to the rate of relapse in our program. More so, water, sanitation, and hygiene. It is in the NFS survey I talked about the other time that was done in November 2021. It was reported that in Borno State there is poor access, poor uptake of adequate hygiene and all that. I think hygiene should also be looked at, because when a child have access to improper hygiene, the child can come down with disease condition like diarrhea disease, because of consumption of dirty food or food that contain germs. So I think these are, if we can actually embolden this can actually help to an extent to prevent relapse.
Olive Mutamea of Save the Children International Borno said the main way of preventing relapse in children under 5 is to look at resilience projects.
A collaborative effort in addressing malnutrition, not just to look at it as a health component, as a nutrition component. We need to look at it multisectorally. We need to advocate for it multisectorally, so that we can address the issues of malnutrition in our society, because there are many factors, from the quality of health services they are getting, from the prenatal and maternal care that is being provided. So if we do not have the ANCs, we are not providing those services, we are not having immunization services, all those factors contribute to malnutrition in one way or another. So we have to look at addressing malnutrition from a multi-sectoral point of view.
There was no relapse case at the time of our visit to the MSF Belgium 120-bed Nilefa KG hospital in Maiduguri. The hospital said this is as a result of measures put in place to reduce relapse cases in the facility.
We started different strategy, more especially our community approach strategy, doing follow-up for patients after discharge to make sure they are taking the plumpy nut afterward, and then also giving them advice on how to not fall into malnutrition again. And basically when they are in our facility, we normally health educate them to sensitize the community as well. You know, also another thing that always leads to relapse is that people don't go to the facility on time. So when their child is sick, they don't seek treatment on time. Before you know, the child got malnourished. So we worked a lot on their health-seeking behavior. So they normally come on time to the facility, which is really reducing this relapse rate.
During the visit to Borno State, the reporter found that some women sell the plumbing nuts given to their malnourished children. To get more plumbing nuts to sell, they register their malnourished children in different treatment centers under different names. Findings show that the Kasuwan Shanu Junction, Maiduguri, is a popular place for buying and selling diverted plumbing nuts. Saadatu Mohammed, a displaced mother of 9 children from Baga, said whenever she receives the RUTF, she shares it into 2 and sells the other half. She said she gives the remaining half to her child because of poverty. She uses the money to feed herself, her husband, and her other children. She said she would stop selling the RUTF if she's helped with another source of livelihood. Fatima, a widow, has a daughter who has been treated for severe acute malnutrition several times. She also sells the RUTF she's given. A leader of the RUTF retailers at the Kasuwan Shanu Junction said health workers usually give the mothers 18 pieces of RUTF. Then they sell 8 to the retailers and go home with the remaining 10 for their babies. She said that men who buy the RUTF from them eat it with bread. Explaining the implication of this on children, Sefia Yunis of Shuari OTP Center had this to say.
This RUTF, we are giving it based on the body weight of the child. So we are expecting a minimum amount and maximum amount of gram that the child will gain within that week. So if that child is deprived of either a sachet, let's take a minimum sachet, let's take 1 sachet, that child will not sustain, will not get that weight that we are looking for after the week. So as such, he will start losing weight, he will be returning back to his normal position. But if a child is not deprived of any quantity of the amount that was being given, you will see he will be gaining weight progressively to attain the discharge criteria.
Olive Mutamia of Save the Children International Maiduguri said not giving the child all the therapeutic food prescribed would affect his or her severe acute malnutrition recovery outcome.